Welcome to Understanding Traumatic Brain Injury. I am your host, Sue Dexter. We are here to educate for better understanding of brain injuries, bring awareness, and most important, support survivors and caregivers. And we have had an influx of many ABI. So I got this idea of having someone come on and talk about TBI and ABI. And my guest today is Mark Flatt. He is a severe TBI survivor and registered nurse. At 23, a car crash left him unconscious for a week. He rebuilt his life as an ER and neuro-psych nurse. He founded Detours after seeing how little families understood brain injury. He has lived both sides of the bed rail. Thank you, Mark, for being here.
Thank you for having me. I appreciate you and anyone watching. Um,
So let's see. So you lived through a severe TBI at 23. When did you
oh,
first hear the term ABI and what clicked for you about the difference?
it's I wouldn't say there's any specific time. I mean, it's a clinical definition of exclusion, really.
Mm,
It's not a definition that has a like it's used by a lot of different people in a lot of different ways. Um, So I wouldn't say there's a specific time, and it's kind of changed a little bit over time because brain injury, at least clinically, didn't get a lot of focus until much more recently. Because to be blunt about it, most people with brain injury, whether traumatic brain injury that is mechanical, um, died.
mm-hmm.
That is physical traumatic brain injury. Some did definitely survive, but not by virtue of anything we did in the healthcare community. Um, so as strokes, that was mostly an elderly problem. And again, most died or ended up in a nursing home. So, it's only with recent changes in emergency critical care and trauma medicine that we started to focus more.
Okay. Um, so in plain English, uh, my screens, I have so many things going here. Plain language, how do you explain TBI versus ABA to families in the ICU who just heard about the terms?
Um, Frankly, I really wouldn't I would give them the specific description of what happens. So if somebody lands in the ICU or the emergency department with a stroke, I'll say stroke. If they land in the um, ICU, or, whatever, with a traumatic brain injury, I'll use traumatic brain injury. So they will get the appropriate diagnosis. Now, if it's a group or if it's, like something like this, the term ABI is kind of a catch all. It is any kind of brain injury that somebody has after birth. So it includes traumatic brain injury or mechanical brain injury, but it also includes so called non traumatic brain injuries. So things like strokes, things like, which can also be traumatic, but things like strokes, encephalitis, meningitis, um, things like um, yeah, heat exhaustion leading to brain damage, extreme cases, radiation exposure, if you're treating a brain tumor, which also can be uh, a an acquired brain injury. Um, any of those kind of things, any kind of brain injury which you acquired after birth. So a healthy neurotypical brain acquires damage after birth. That's pretty much what it is. So any kind of brain injury, whether due to mechanical force, whether intentional or accidental, so violence, gunshot wound to the head,
Mhm.
whatever, that's an open head injury. Closed is something like car accident, a concussion, whatever. That's closed head injury. Those are both kinds of traumatic brain injury. Or non-traumatic brain injury, which is meningitis, encephalitis, and those kind of things. Stroke, that is a non-traumatic brain injury. Um, a fever of 105 for 2 days, which they really can't bring down. Usually that's a metabolic problem. Blood sugar down to 20, and you manage to survive that, causes brain injury. Radiation treatment for cancer, chemo, certain pharmaceuticals, especially if you have a toxic reaction, a severe allergy, cardiac arrest, hypoxic incident, non traumatic. I'm not talking about emotional trauma here. I'm talking about
Mhm.
mechanical trauma, as in a
Right.
force applied.
Mhm.
That is also an acquired brain injury. A healthy brain before, damaged after birth. And there's your key, after birth. So something that happens in utero, or genetic or chromosomal damage, or something that is epigenetic. So things, or polygenetic. So Alzheimer's, no, that is not considered an acquired brain injury because it likely has epigenetic or polygenetic causes, but you're born with it. At least that's what we believe. We're not quite clear on all the, but
Right.
cancer. Uh, that's
Most
a
common.
we're not sure. We know it's a genetic problem, but usually it's de novo, meaning a spontaneous mutation or change in the genes. So it's one thing if you inherit it from family members, a
Mhm.
vulnerability and increased likelihood. It's another thing if it's like spontaneous in you. In that case, it's an acquired brain injury. So it's kind of fuzzy there. But
Right.
if you came to me with a loved one and said, "Hey, what's going on here?" I would say, traumatic brain injury. I'd say brain cancer, or leukemia, secondary effects, or encephalitis, meningitis, meningio encephalitis, sepsis. Sepsis also causes brain injury, but those are all, they all fall under that big umbrella
Mhm.
of acquired brain injury because they were healthy before, their brain is damaged now.
Right.
But it did not happen during birth. Now, immediately after birth, if the doctor drops the baby on the floor, head injury, and yes, that kind of stuff has happened, um, that is an acquired brain injury because developmentally they were normal. And there are also overlap cases where you've got two different brain injuries, where you have a developmental problem like, say, Rett syndrome or Dravet syndrome, or something else like that. But then you also have, say, a stroke, or you have or you have trauma, mechanical trauma, that is traumatic brain injury,
Mhm.
and so both of them. One is an acquired brain injury. The other one is not. Is a genetic disorder.
Right.
Seizures. If you have epilepsy, um, and the anoxic episode causes brain injury,
Mhm.
you got both. So it's not a neat, easy thing. It's more a definition of exclusion, what it is not versus what is. Acquired brain injury is anything that is not in utero, birth, chromosomal, genetic, or progressive dementia from genetic or epigenetic cause.
Mhm.
So it covers pretty much everything that you're not born with or that was not in utero.
Right. Right. So you have been a patient and a provider. How does the diagnosed label follow someone through rehab and insurance?
Um, Labels. Yeah, this is one. Excuse me. I apologize.
That's
I
okay.
have problems with,
No worries.
I have allergy issues. Um, Makes me sniff, cough, all that fun stuff. Um, so, um, a lot of people stake everything on the label they get, but um, usually, there are different kinds of labels. So there is like And this is determined. This is more of an insurance company thing.
Mhm.
Um, excuse
Yeah.
me, water.
Um, that's
So
alright.
this is
Take your
more
water break. No worries. 'Cause, there's, like, the regular commercial insurance versus workman's comp. Who's gonna
federal,
cover what? Yeah.
VA, Medicare, Medicaid. That whole thing is a dark art.
Yeah,
I
I
got
deal with them. I deal with them on my
I
job.
I was staggered when I saw what is involved. I mean, I'll be a provider 10 times you could take the handling prior auth. And I mean, I have to debate that often. I'll do what's called peer to peer, which is where you have to have back and forth
Mhm.
in order to win somebody's, like approval for medication treatments or whatever. It's ridiculous, but it is the way it
Yeah, it
is.
is. Mhm.
Um, Makes me angry. Anyway, so a physician may, if they don't quite have enough, notice you work with a book like the ICD 10, 11, whatever, DSM-5, TR, the medical diagnosis handbooks,
Mhm.
and they'll have criteria that you need to meet for to make a diagnosis so your treatment is paid for. Sometimes they'll do what's a provisional diagnosis, which means we don't quite have all the pieces, but we believe this is the case,
Mhm.
um, because it's a numbers game for insurance.
Mhm.
So you may only get a provisional diagnosis. I have a video based on, why diagnose in the first place, self-diagnosis, stuff like this. Anyway, so you may only carry a provisional diagnosis because they just can't get all the pieces required. But that's usually enough to at least get some funding. And it's important that these certain criteria are met in order for the company to keep paying for treatment. If
Mhm.
you don't meet certain milestones or if you don't meet the necessary, and again, this is why I say insurance and like that kind of stuff's a dark art. It is an entire training thing. There's a degree in this kind of thing. Um,
Mhm.
and this is why some people end up losing, being discharged early because they don't meet certain requirements for insurance.
Right.
Um,
Then it gets
but
tricky.
yeah, yeah, and these diagnoses are necessary, but all they are is, ways to make sure that payment is met, things like that. And it also is a way for us to communicate with each other, medical
Right.
professionals, health professionals and educators and paramedical personnel. I mean, educators, especially special educators and paraprofessional, they know what the terms mean also.
Mhm.
And they understand in relation to their field what it means. Um, Traumatic brain injury, if I remember correctly, is also a special education category.
Yes, it is.
Um,
Coming from a
so
background of special ed. Yes, it's a
But
form
there
of.
is a difference between that and stroke, which would be under other
Mhm.
health conditions, stuff like that. And kids do have
Yep.
strokes. How what you do in education for somebody with a TBI obviously relates to what I, as the clinical provider, if I make that diagnosis, you will provide certain educational supports in relation. So it is a way for us to simplify and to communicate quickly, more
Mhm.
efficiently, because there are certain components. Now, if I just simply say acquired brain injury, that could be anything.
Yeah, it's very broad, very broad.
So the best way is to, especially if you want to communicate clinically, I will not say acquired brain injury about somebody to another medical professional. I will give them not only like traumatic brain injury, stroke, I will be very exacting, when I'm commun.
Yeah.
So I would say, epidural hematoma with loss of consciousness for less than a week, neurosurgical interventions necessary, shunt placed, and there are numbers under, for example, the ICD-11, which allow me to be extremely exact. And so I will use most likely a chain of numbers, da, 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 and to communicate this. Now, obviously, what I would do is hand this off to somebody who is trained how to convey this,
Mhm.
because I don't know that bit of black magic to convey it right. So if I make a report or whatever, I type in my advanced nursing notes, and like,
Mhm.
I'll let them convert it, because it's always
Yeah.
changing, and I have no idea all the stuff that's in there. But
Yeah.
I will make sure to hit the key points in the diagnosis. Anyone can open that book and look if they're
Oh,
really
yeah.
interested in the
Mhm.
ICD-11. And most medical professionals have a copy of the ICD-11 and like the DSM-5 TR. I have a full medical library over here. I've got all that stuff because I
Yeah.
need to know.
Well, you did mention, like, special education. I'm a former
Yeah, you
paraprofessional.
you
I
guys
worked
know.
yeah, I, worked in an ABA, which is Applied Behavioral Analysis Program for
Mhm.
autistic children for 7 years. I learned a lot in
Yeah,
behavioral, because 'cause you're basically doing behavioral modification all day long and reshaping someone that has, um, it's like I said, there's a window of opportunity when you have someone that's agitated, de-escalate a situation. And I've used ABA on my own husband with his TBI. Um,
that works best for, and it's
mhm,
the certain cognitive and psychological procedures work best. We don't have any
oh,
medication we can give you to prevent or reduce severity of brain injury, neuroprotective agents. There's some that are in the lab that
mhm,
look promising. Xenon gas seems promising for neuroprotection. So does ketamine. There are a couple others, but it's a big jump from rodents in the laboratory to human
right,
brain.
right.
Even
And
though there are a lot of similarities, many
yeah,
things we thought were great.
there's also, it brought to my memory, there is a place near me in Westfield, which is a like a day program for people with traumatic brain injury, and
Mhm.
they work with them on how to schedule their lives. It's
Yep.
I
Mhm.
believe it's from I forgot BIC something. I'll have to look it up and I'll put it in the comment section where people can look in their area to see if they have them, if they're adults. Um,
To pay you, though, as an ABA, we need to use those codes to make sure that you are paid. So, it's like if I were writing, a treatment plan for a medical treatment plan for a client, I might be, they've been, every
right.
time they're in this environment, they lose control of themselves. So I'm writing an order for, ABA for noise desensitization or whatever I need to specify, and then I will
Hmm.
have to put those codes in, the ICD codes in, to make sure you get paid. And this is another reason why a diagnosis is important, because the insurance company will ask, well,
Hmm.
why do you need ABA,
Right.
why are
They
you
need to know all
specifying,
that information for services.
right?
And
And that makes sure you get paid. Or why are you giving a beta blocker?
mhm,
Why are you recommending to the doc, or why are you writing for? I mean, nurses have certain privileges too. It's like, why are you know, this is why.
and
And again,
yeah.
that code.
Yeah. And as of January 2025, CMS recognized TBI as a chronic condition.
Mhm.
Um, and what is the changes for the survivors? And I know there's different levels of TBI. Is
Yes.
there the same levels for ABI?
Again, ABI is more a blanket term, so it's not used as a diagnosis per se. It just is like a catch-all.
Hmm.
You need to be specific with what kind. Um, within a TBI is a all Cokes are sodas, but not all sodas are Cokes. All TBs are acquired brain injuries, but not
Hmm.
all acquired brain injuries are not all TBIs or acquired brain injuries.
Yeah. Um, and
So,
I
yeah, ABI is not
yeah.
used as a formal diagnosis. It is a
Oh,
way of
great.
organizing.
That's the clarification because I have read people that were confused between are they the same or are they, you know, like TBI, you have mild, moderate, and severe. And
Severe.
I know they're changing that too.
Yeah, finally. And I would
Ch-
argue there's also catastrophic. And then see,
Right.
here's the problem with all this. Um, the GCS, the Glasgow Coma Scale, which is
Hmm.
what's used to derive mainly the motor portion is your best way to determine. It does not tell you outcome. It does not give you prognosis
No.
because there are people with severe who come out pretty darn well in the end.
Hmm.
And there are people with mild who can come out fairly impaired. I prefer just to say they've had a traumatic brain injury, and then you wait, you rehabilitate, you do everything else. There's this other thing called the Glasgow Outcome Scale
Hmm.
Extended. Even it is not quite granular enough to differentiate, but the GOSE, the GOES,
Hmm.
at least points you better and can help you. And as you look at the patient after they're done with rehab, where do they land on the GOSE? And maybe 6 months and a year later to see how they're profiling. Because the GCS really was never meant to be used the way it's being used. It was used to help back in 74, I think, is when it came out. It was intended to be used, and this is for traumatic brain injury. This is not for, yes, it can be used for strokes and for other things where unconsciousness. It was used to measure the degree of unconsciousness, how serious a coma is, hence the C in GCS, Glasgow Coma Scale. If somebody comes in unconscious, you use this to the ED.
Hmm.
They come into the ICU, and I'm not talking about chemical coma. I'm not talking about induced comas. I'm talking about naturally unconscious.
Right. Right.
You could
Like
call it the
right after
GUS,
the injury.
right? You could call it the GUS, the Glasgow
Right.
Unconsciousness Scale. Doesn't matter, but it is not prognostic.
Hmm.
There are other signs that you can look for, to help you make that. But again, because there's so many factors that go into there,
Hmm.
age, are there other traumas? Is there bodily trauma? You know,
And where is the injury in the brain as well?
Where's the injury? Now that's where the motor skill comes in. That kind of tells
Hmm.
you roughly where, what
Hmm.
pathways are disrupted. So, somebody who lands to bottom for the motor portion of that scale, it's a very deep brain injury.
Hmm.
Not so good.
No.
Whereas, if they're mumbling or making noise and stuff with their unconsciousness, it's much higher. And so maybe better, maybe.
Hmm.
But what if there's bleeding with it? What if there's
Right.
edema?
Right. Right. Which majority of them might have.
So, meh. What if there are
Yeah.
other problems? What if they have an infection as
Right.
well?
Right.
What if it's a seizure?
Right.
So, this is not a tool for prognosis, for telling you the future, for telling you how they'll do.
Right.
It basically is useful for physicians, nurses, and stuff to know what kind of resources they'll need.
Right.
So, it's like, will we have
And
to intubate the patient? Yeah,
right.
maybe. Will they need neurosurgery? Yeah, maybe, or nah, they probably won't need
Hmm.
neurosurgery. Will they need to go to another hospital? Will they need to go to a bigger trauma center?
Hmm.
Yeah, no, then we can handle them here. That kind of stuff. And that's what it was intended for. It
Yeah.
was not intended to be used as a
Right.
prognostic tool.
And it's really hard to tell what the future will be because everybody heals a different way and
Exactly.
there are symptoms later on that show up.
Well,
Um
that relates to the problem with brain scanning. I have a video on that one too. Um, when you go to the ED, the emergency department is looking for neurosurgical emergencies. When they scan your head, when they do a CT scan, if they decide to do one, they're looking for something that needs immediate neurosurgical intervention. They're looking for something that may require you to go to a major trauma center. They're
Mhm.
not looking for brain injury per se.
Mhm.
Why? They can't detect it. They can see like major, like a major massive bruise or whatever else. But most of the damage for mild, moderate, even some severe brain injuries, the resolution isn't high enough. Even with an MRI, it's like you can see really big stuff, but you can see bleeding.
Mm-mm.
You can see edema.
Mhm.
You can see, displacement of the
Mhm.
midline. Serious stuff that needs a neurosurgeon like yesterday.
Mhm.
But stuff that will affect your executive function, stuff that will affect your vision, your balance, things like that. CT scan isn't going to necessarily pick that up unless you're in Crapsville already and you need a shunt, you need craniotomy,
Mhm.
you need, like major surgery. And in that case, you're already going to be handed off to the neurosurgical team to begin with. So
Right.
you're either if you're in county general, you're going to be flown, or if you're in a major trauma center, the neurosurgeon just wants to see where it is. So when they crack your head open, he knows where or she knows where, because yes, there are more and more female neurosurgeons now. That used to be a boys only club for a very long time. But he or she is going to need to see where they need to cut. And that's why they'll be doing the CT scan. There is an exact recipe now by the American College of Surgeons, treatment of traumatic brain injury. It is evidence-based medicine is what the studies say you should do. Step 1, step 2A, B, C, step 3, step 4A, B, C, D, E. You literally go right down that list because it's what research shows you should do, and every hospital will follow that. It'll tell a small hospital if they should fly this person. If you meet these numbers in this subscale, fly. If you don't, you can treat them locally. Boom, boom. When you should call the neurologist in, when you should transfuse blood. If you don't have this type, you could transfuse this type. There's a whole menu of options
That's
in
that's
every
awesome that
accredited
they have
hospital.
that now. That's awesome that they.
This has been around for a couple of years. There's
Yeah.
the advanced trauma training and specialized nurses or experts in trauma and emergency. Whole thing. And things change. New research, old things we used to hyperventilate, and they said, no, research says it doesn't help, except for if your brain is herniating, like
Mhm.
squeezing through the opening at the base of, and it's constantly changing. There are research committees of doctors, nurses, and physiologists and stuff who are always doing research. And
I have a what do clinicians miss in the first 30 days that the families notice at home 6 months later?
that relates to the brain scanning that I'm talking about. Oftentimes, somebody would say, again, this is traumatic brain injury. This is, although it's possible with certain acquired brain injuries, oftentimes with people expect that when you go to the ED and you get a clean bill of health, that it means you don't have brain injury. That is not true. All it means is you don't have a neurosurgical emergency. It means you don't need to be operated on. Because if you
Mhm.
do, they'll send you, but
Right, right.
you still can have brain injury. So when they tell you to follow up, because those scanners, even the MRIs, cannot resolve at microscopic levels. You
Right.
can have microbleeds, you can have a seizure,
Mhm.
you can, have executive deficits, trouble organizing, planning, thinking, focusing. The ED is not meant to replace your primary care physician. The ED is not meant to substitute or to tell you everything is perfect. You need to follow up. And especially if you're noticing you're having trouble thinking, remembering, focusing,
Mhm.
If people say you're more irritable or whatever, it's very possible that you've got some brain bruising or that you've got, some symptoms. The ED's job is not to look for brain injury. They're ruling out neurosurgical emergencies or life threats, hence the term emergency for
Hmm.
emergency department. So
Yeah.
yeah, they definitely miss stuff. And that is because they are not there to, like,
Right, right.
but
So
yeah, they definitely will miss, some, especially for mild traumatic brain injuries or like a TIA, transient ischemic attack is a warning that you are at risk for a genuine, honest to God stroke. That
right,
means get thee to a physician immediately. See your family doctor.
right, right. With your
New onset severe headaches.
yeah,
Get thee to a physician right away.
right. Anything new? Because like
Hmm.
I brought up, we've had a conversation before this live about my husband with the tremors, and he had 2 or 3 episodes of body freezes where he couldn't move his body.
Get thee to
Um,
a physician right
we've
away.
Yeah, we have a neuro tremor specialist working with him.
Mhm.
Um, and with your TBI, in this field of being what you're doing, it helps you understand your own TBI at all?
Mhm. But to be honest, doctors and nurses, some of the worst patients.
My husband, no,
Um,
my husband tops that because he was doing things he wasn't supposed to be doing.
Part of it is because, you mentally go through, I mean, you're either a hypochondriac on the one side when it comes to things outside your field, so you over worry, but in your own field, you're pretty confident, nah, that's this, and the other thing. It means you can miss stuff. So we tend to be bad patients. And when we're under care, we tend to be bad patients too. Not because we're extra, bitchy or anything. I don't mean like that. What I'm talking about
Mhm.
is like, oh, okay, I'm fine. I'll get that, that kind of thing. And, it can lead to problems. Or I'll do that. I could do that. Don't do that. It's bad.
Yeah. So what does recovery actually look like after maybe 2 years for most that they think they could stop?
Um, Again, acquired brain injury isn't a singular thing. So what kind of condition are you asking about?
Just the basic, somebody with a TBI or
Okay.
um
Okay. How
someone
bad?
that maybe some moderate. Why don't we go with the
All right.
middle?
Moderate and severe tend to lay together. They look a lot more alike. So, did the person have rehab or not?
Yeah, for a little while.
All right. Um, it depends on what area of the brain's injured. So if it's frontal stuff, they will still be struggling. After 2 years, still be struggling with behavioral issues still. Even if they've had
Mhm.
some rehab, changes of environment will be problematic usually. This is kind of a usually sort of thing. Um, may still be somewhat combative. They may be, oh, maybe not. Depends. They may be just sitting around all the time, staring at TV, whatever. Is everything okay?
Yeah, I
Anytime.
just gotta unlock my door.
Okay.
1 second. Sorry, my daughter needed to borrow something.
Okay.
She's getting ready to go to work.
All right.
Um,
Adynamia is a problem. Usually that one kind of lingers for a while. That is, while you have
Mhm.
ideas and you want to do stuff, you can't shift into gear. You have trouble getting started.
Right.
That's a significant problem for a lot of brain injury survivors, even on the mild side. That's a frontal symptom. In psychiatry, they'll describe it as abulia. You see this with schizophrenia also. Trouble shifting into gear. You've got all these ideas. It's not laziness. A lot of like people say, "Oh, he's so lazy. He won't do this or that." It's kind of like your car. The engine's on, but you cannot shift the transmission into drive
Right, right,
or reverse.
and some right, and some do develop mental health issues as
Yes,
well.
that can happen too. Again, trick is there's pseudo depression, which is abulia or adynamia versus genuine depression. One of the key differentiating factors here is a depressed mood. If they're indifferent, it's more likely pseudo depression, and
Mhm,
it's treated
mhm,
differently clinically from genuine depression. Antidepressants will not help pseudo depression. This is where both ABA type interventions and stimulants, low dose stimulants help. Not perfectly, but and then actually engaging them. It's like, hey, come on, stand up. And very structured, direct instructional kind of. We use direct instruction in rehabilitative techniques too. Um, do this,
right.
do this, do this. Scaffolding to support. Again, something we use. I know we borrowed that from education.
Mhm,
So treating pseudo depression is different because it's a cognitive problem. It's not an emotional problem.
mhm,
And depression we treat, you know, but you start with very low doses of medication. Work your way up. Prozac is one of the recommended treatments for depression for brain injury that research shows. Amitriptyline
mhm,
is another one, but again, really low. Work your way up. Very low doses, working your way up.
mhm.
Um, as well
What
as
was the
the
hard
usual cognitive
right,
behavioral stuff.
right, and what was the hardest part for you when you suffered a TBI?
Couple different things. Memory, which is still not fabulous, but I'm much better at it. I just have to rehearse a lot more. Short-term memory sucks. I also forget to remember, which is different from just short-term memory. Forgetting to remember is I retain something, but I forget that I learned it. That's a little sticky there. It used to be problems with anger and aggression. That is very common. Frontal lobe
Mhm,
injury. That's more an issue with impulse control and like sensory overload relates to that. Too much sound,
mhm,
too much noise, very easy to set that off because it's like,
mhm,
flooding your engine for your
yep,
car. Um,
mhm,
if you want to help somebody with that, everybody dealing with a person needs to be consistent. And that relates to applied behavioral analysis. Again, ABA is one of the best ways to
mhm.
deal with,
It's
especially with these.
repetition, concrete,
And
yeah,
everyone has to handle it the same way. You can't have, each person, "Oh, you poor thing." Nope. Everyone's got to be consistent, or else it
and
doesn't
on the
work.
same page. Right,
Right.
exactly.
And so you cannot have somebody undermining the approach. It's got to be consistent. Um,
Mhm,
a lot of people with problems with aggression and those kind of pseudo psychopathic syndromes, the like aggression or like a lack of empathy and stuff. A lot of that comes from the underlying cognitive problems and the problems
right,
uh, with comprehending what's going on. Many of them are not affected by reward or punishment because those circuits are
mhm,
disrupted in the orbitofrontal region right under here, um,
yeah,
as well, which is necessary to help predict consequences. And if those circuits
especially
are
if they can't
disrupted,
rationalize it.
those circuits are reciprocal back and forth. And
Mhm.
if those are disrupted, they cannot make a prediction effectively as to what the consequences of behaviors will be. Many
Right.
patients with that have problems with fear or anger perception. They can't read faces very well. So they
Mhm.
can't recognize what a fearful face looks like or stuff. They have to actually be retaught. And there are techniques to do
Mhm.
that. Certain neuropsychologists and cognitive rehab specialists, stuff like that, they can help, like teaching that. But those things can be lost too. For me, it was memory. I'm emotionally labile, so my feelings can quickly go from one side to the other.
Mhm.
Um, it's been so long. Most of those are mostly resolved. Also, like as I was studying things like that, it requires a very rigid routine, which helps.
Right.
Emergency
Yeah.
medicine is very
Mhm.
structured and very organized. A, B, C, D. Most people see TV shows and assume, oh, it must be chaotic. There are recipes for everything.
Mhm. Mhm.
Memorize and learn those. Tick, tick, tick. And if that doesn't work, then you do this. If that doesn't work, you do this. And all the movement of people, each person has their role. They're supposed to do this. If it's truly chaotic, then some wheel isn't turning as it should be. But usually they're highly
Right.
structured and disciplined, and that helps too. A structured and disciplined environment, especially for work.
Mhm.
So if you're a higher functioning
Mhm.
person, you still need a very structured, organized environment. That helps me.
Mhm.
Um, and even somebody, again, working with special needs, that structured environment helps. Cues,
Yep.
lots of, again, that is how you best work with people with, more serious, moderate, severe brain injury. So to your
Yeah.
bathroom, they're
Transitions.
still fighting,
Yeah.
yes, and pre-alert for a transition. Hey, in 20
Yep.
minutes, don't forget this,
Mhm.
and help with transitions. It is what you know in special education. It's the same techniques you use whether you're working with an autistic kid, whether you're working
Mhm.
with an intellectually disabled kid, or whether you're working with a child with traumatic brain injury. It's the same for adults too.
Mhm.
You
Mhm.
have
Exactly.
exactly you have exactly what it takes to take care of people with traumatic brain injury.
Mhm.
That is exactly the recipe. In fact, so much of what we use in rehab comes right out of the special education side, and vice versa. There's such a thing as neuroeducators. There aren't many of them, but
Mhm.
it comes right out of the same playbook.
Yeah. I no longer work as a sped paraprofessional due to my our financial
Right.
situation. I had to change.
Mhm,
I'm still helping kids in a different way. I work in the mental
mhm,
health field for Center for Human Development
right.
in the Children Behavioral Health Initiative as an
Mhm.
administrative assistant. So I have to get the pre-authorizations for services and get those services for them.
But for anyone out
And
there, if you want to, like source something to actually help guide you along, just take a look at like any of those kind of books. It's
yeah,
pretty much the same stuff. Just one key thing is be respectful. If it's an adult, you don't treat them like a child. Um,
yes. And I have a story about that. My husband went into rehab. They were used to dealing with severe, not moderate.
mhm,
And I didn't, they wanted him to go to Spalding, which is in Boston. And I'm
okay.
like, part of his rehab is the people around him, his kids, his family, his friends, familiarity.
Mhm,
They were working with him like he was a child. And I'm like, why don't you
mhm.
start at the chronicle age and do a backwards chain until you hit a wall?
Seems
and
reasonable.
then you would have a better scope of what damage was done. Um, so in a way, I was teaching them about moderate, someone that can be functional.
Mhm.
It was
Even
very
somebody who's
difficult.
severe can be functional so long as, you
Exactly.
know, it takes time and effort. Um,
Well, the majority of the people that was at that rehab were so severe that they were pretty much wheelchair bound. So my husband was a
oh,
test, and I
something
basically,
else. Just because somebody
yes,
has motor deficits does not necessarily mean they have cognitive deficits. So if somebody's wheelchair bound or needs crutches, or
exactly,
I use a cane.
exactly. And that was the issue I was also having while he was at that rehab. Is like, they didn't really do much with them. One time
That's
I
more
told
a
them,
problem of
you need,
fitness.
and I told them, you need structure, but don't treat him like he's a child. And they came up with a schedule of his day, which was great. But the only
Wait,
thing is, it was meant for like a child.
that is a problem of fitness. How well he fit is there. He did not
Hmm.
fit well. He probably should have gone
No.
to a different place.
So in the
Because
meantime,
some
most of his,
institutions deal with severe, and now I'm not saying they should treat adults that way because they're still adults. But
mhm,
we're still all learning, how to deal with. I mean, there are experiments, with medications and stem cells. Oh, by the way, um, I know there are people who try the stem cell thing. I want to throw this one in here. They help reduce inflammation. They do. And there's some positive signs, but we're not at the point where they grow where they're put. They don't. They just
right.
die off. But they do reduce inflammation. So that is a positive. Research shows we don't know the signaling yet. And that's part of the problem. We don't know how to tell them, oh, you're supposed to grow up and turn into a permanent adult brain cell. We don't know how to tell them that yet. So they help reduce inflammation and then they die.
Yeah. Hmm.
Yeah,
That's
I've done
interesting.
research too, all the way back before I was hurt. And it was frustrating then. It's still frustrating. Mm.
Yeah. Because we're missing some components and
We're
stuff.
missing a
We're
lot
still
of
learning.
components. Yeah. Again,
Yeah.
because
I was being
most of us
generous.
would
I
have
was being
died.
generous.
Yeah,
Yeah.
most of
Um,
us would have died anyway. I would have frozen to death or, without the proper ventilators and drugs and things. 50 or
right.
60, maybe 60 years ago, I would not have survived. Hmm.
Mm. Well, my sister did with her severe head injury. She survived, and she had a severe, she was in a coma for 10
Mhm.
days
Now, was she on a
and
vent?
partially paralyzed. Huh?
Was she on a ventilator? Well, she was
Was
on a
she?
ventilator because she was.
Yeah, and she was temporarily paralyzed on her left side, which she regained, but to this day, she still has some issues with her left side. Um,
Sounds like she did pretty
and
well.
yes, she did. She's a fighter. She's a scrapper. She inspired me to go into special
Mhm.
education and work with special needs kids because I saw the um what they didn't do for these kids, and when I worked in the ABI, I have a lot of moments where there were uh
Mhm.
you learn from, and you have that breakthrough that you've been working so hard for, and when you do it, it's like no money in the world can make you feel what you feel. I can't even describe it when you break through that
There's like so
um
much that it's frustrating and yet at the same time rewarding when you get a win. No, I understand it totally. I mean, in medicine, it's like that because there are a lot of disciplines in medicine that do not receive the funding they should. And, you
no.
just work with what you got. That's what you can do. Is work
Mhm.
with what you got.
um Finish the sentence. The thing I wish every person with a brain injury knew is.
Mm. You can do it. Um, you may not do it the same way, but you can do it. Um, this is something when I go into to talk to patients with brain injury or whatever. Um, I've got my blues, I have my stethoscope, and everything else. They probably expect just I'm another. It's like I'm a survivor, like you are. Yes, it's been a long time, no question about it. But back in, every day is a grind. It's a push. I was talking to my wife Stacy earlier today about it, and it's like you can do it. It's like everyone's entitled to some, oh, woe is me, all that kind of thing. But there comes a time when you got to put that down and you got to push. Will it always be
Mhm.
successful? Nope. You'll have setbacks, guaranteed. But
Mhm.
the only time you've ever lost is when you finally just is when you quit, or when they throw dirt on you at the end. But
Mhm.
you can do it. It requires you know, a lot of pushing and shoving, no question about it. And sometimes it requires support from family, friends, things like that. And sometimes it requires ignoring them.
Mhm. Oh, yeah. I've had many situations with my husband that I had to um ignore certain behaviors to let him know that I wasn't going to tolerate it.
Hmm.
And I picked my battles because I don't want to degrade
Hmm.
him either. When he came home, it was a rude awakening because he was a stranger.
Hmm.
And it wasn't just for me, it was for him too. And a
Often,
lot of his therapy was at
oftentimes,
home.
oftentimes, a lot of people say, "Well, I'm a different person." It's like, no, you're not. Not really. What it is old behaviors from the past, things your parents disciplined out of you, or like things that people didn't find funny that you joked about or you did, kind of pushed out. Um, or things that were positive that were rewarded came up. But usually, it's an amplification or suppression of things that from before. So
Mhm.
it takes the same kind of mentality to fix it.
Mhm.
Again, ABA and those kind of techniques requires sometimes a heavier hand to deal with it. Not abusive, never, but
No.
it requires again that stick to it. Everyone has to play from the same sheet of music in order to accomplish the change. Sometimes it may take a year or two, or
Mhm.
3 or 5, but
Mhm.
you can, you know, it requires patience, persistence. You can do it.
Mhm.
And same
Mhm.
applies to family.
Well, here's a
Do
prime
you want it
example
enough?
for right. Prime example was when he first came home. I would describe old Dan and new Dan. My husband's name is Dan.
Mhm. Yeah.
If the old Dan could figure something out real quick and fix it, we had a leaking faucet and it was leaking for 4 months. I let it leak because I knew it was important for him to figure it out and fix it. And he did. And it made him feel proud that he was able to do that. That was part
and
of my therapy at home is the
and
patience.
the thing is that over time with practice and rehearsal, get faster and
Mhm.
better at that and more efficient and pretty soon, but it's persistence and patience, which is key.
Mhm. Yep. And like you said, ABA is that. It's an intense program because you're butting heads with behaviorals that are not appropriate and you're trying to mold them into a better behavioral. So there's discrete trials that you do. It depends on the child, how severe
Tracking,
it is. If they're
starting
stimming,
small. It's much like that.
non-verbal.
It's how we handle with medication.
Hmm.
Start low, go
Hmm.
slow, but go. And if you hit a wall with a medication that's not working,
Hmm.
try another. Start low,
Hmm.
go slow, but go. And people get impatient. They want a big red button to push to
Yep,
fix it.
right now.
It's not how it works with pharmaceuticals. It's not how it works with somatic treatments. It's not how it works with
Mm-mm.
psychological treatments either. It
Nope.
requires patience and persistence. It is probably one of the most patience demanding divisions in medicine. It's
Mm-hmm.
not instant reward. I mean, emergency
No.
medicine can be rewarding like that, but uh, brain injury medicine is a very different field.
Yep, it is. Definitely. And it was funny when I first started working with children. I work with profoundly handicapped children, and I would see the behavioral kids across the hall, and I'm never going to do that. What did I end up doing? ABA, which was, like I said, rewarding.
They can be
Um,
very sweet though too.
yeah, they can. They can. I enjoy teaching them how to express themselves because a lot of the antecedents of their behaviors was
Mhm.
because they couldn't express what they needed
And that is
and
exactly true
lack
with
of.
people with brain injury. They often have
Mhm,
trouble
exactly. I was
communicating.
gonna say that. Right, because they can't express a lot of times.
They may not even
Um,
know that they need to express it. They feel it, they
right,
can't
exactly.
exactly put it into words. And so they need to learn those skills. Again,
Mhm.
that goes back to ABA. Brain injury medicine, folks.
Um,
It's not
I
easy,
have
but
a
it is a
right.
worthwhile discipline.
To to back that up, I ended up in a life skills program,
Mm,
and I worked with this autistic kid. He was very higher functioning, but when he would get frustrated, he would scream. So I ended up working with the difficult students. This I'll I can't give names, but this
right.
one student one perseverated, constantly said Miss Sue, Miss Sue, Miss Sue, Miss Sue. And student two didn't like it, so he screamed.
Right.
And I said to him, you can use your words. Tell him enough or stop it. Use your words. So one day, student one was going Miss Sue, Miss Sue, Miss Sue, and student two he just got his reinforcement with game time on his laptop. And all you
Mhm,
could see, it reminded me of Home Improvement with, the neighbor. He looked up,
mhm.
looked at the student, called the student by name, and said, enough. You want to know? I did a little happy dance and I just said, you know what? You just earned an extra 10 minutes because you used your words instead of screaming.
And how much is that
And it
like
was
people
like,
with brain injury?
it was right. Exactly.
And that kind of thing, like I said, this is why we use these kind of training techniques and scaffolding, working on skills towards natural environment, all this stuff is a big part
Yeah.
of how brain injury rehab works, regardless of whether it is traumatic brain
Right.
injury, stroke, encephalitis, whatever, all of it. Acquired
And
brain injury, we use the same
right.
technique,
And the
but it
thing is,
requires patience and consistency.
right. And you gotta let that person work at things to see what they can and cannot do. I did that with my husband. With a watchful eye, not on top of them. You can't hover because it makes it worse.
Mhm,
You want to keep the dignity in place.
mhm.
You can watch afar and pick your battles. And it's
Well,
important from the trial and error.
you asked me something as far as a survivor, now something as a clinician. Brain
Okay.
injury is a chronic condition, which means rehab is a lifetime process. We shouldn't
Mm-hmm.
stop with acute rehab and send them home. Patients will need a lifetime support from physicians, nurses, psychologists, educators, as a team, as a rehab team. It is a lifelong exercise to help the survivors and family members,
Mm-hmm.
regardless of whether it's acquired brain injury traumatic brain injury. This is a lifetime endeavor. We are like their PCP, need to be with them, help them grow and recover during their entire life.
Right. And guess what? It's been an hour of interesting conversation. I want to thank you for coming
Thank
on
you for
and
having me.
and you're welcome. And I did promise to do one for you. Just let me
Mhm.
know when that
About ABA,
um
and we will discuss that on, for anyone who's interested, Detours, Understanding Acquired Brain Injury on YouTube. We talk, it's a little more clinical over there because we do try to aim for medical professionals, but there are also plenty for survivors. But it has a little more of a clinical rhythm. Surprise, surprise. But yeah, thank you so much.
you're welcome. And I will have this live up after I edit it. And I think it's very informative and very interesting. And again, thank you for coming on. And we're going to end this with
If you want another one at some point, I'll be glad to help out too.
okay. One thing at the
Yes.
ending part. What is the thing a family member can do tonight after watching this?
Um, I'm hoping that if you're struggling with a loved one or survivor, that you consider searching for a brain injury medicine physician or a sports medicine concussion specialist. If you're having problems dealing with the behaviors, don't quit. Don't walk out, please. It's worth it. Yes, it's a lot of effort. I understand that, but it's worth it, and there are places to get answers. Um, if someone has a stroke, there are behavioral ramifications. Yes, it's our brain makes our behaviors, makes our thoughts, makes our feelings. It is a brain-related condition. So seek out a specialist or subspecialist in one of these disciplines. And I suspect they can help you, but it does require the willingness to take that step. Our medical system isn't perfect by any stretch of the imagination. We all know that, but there are people that can
Mhm.
help you and that have the passion.
Thank you. Thank you so much, Mark. I want to thank everybody that has watched this. I can't see numbers. I'm sorry that there was no interactive of questions, but feel free once I put this live up to ask your questions in the comments and I can pass it on to Mark. Thanks again for joining us at Understanding Traumatic Brain Injury. Please stay safe and have a great day.
Bye.
Bye.